All right, so this is the 2021 protocol assessment review. I'm Paul Zeeb, and Dr. Stoner is with me today, and color commentary will be by Battalion Chief Weber from Truro. So we're going to review the protocol assessment that's been distributed, and we hope to make this relatively short, but also educational and a bit fun. So just a few opening comments. The protocol assessment's an open book review of the protocol. We want you to be comfortable accessing the protocol if you have any questions. This is just your chance to utilize the protocol if you need to answer the questions. Group participation in this event is encouraged. You don't take care of patients generally in isolation. You take care of patients as a crew. So again, group participation in terms of reviewing the questions and answering them is encouraged. There is no pass or fail on this in terms of a grade score. There's no minimum correct number of questions that we are looking for. But in order to pass, you have to take the assessment, you have to sit down and discuss the answers, and you have to review this video in total. And again, group learning is encouraged. So we're going to move on to the first question. I think this one is mine. You have an elderly patient who's complaining of severe chest pain and dyspnea. Her O2 saturation is low. She's diaphoretic, looks uncomfortable. Her blood pressure is okay, but her pulse rate is slow. The daughter hands you a Ohio DNR form that says the patient is a DNR CC arrest or comfort care arrest. And the question is, what care are you allowed to provide this patient based on the Ohio DNR standards? IV fentanyl, can you pace the patient? Can you monitor the patient? Can you provide Cpap? Or are all of the answers correct? Well, my response is they're all correct because this patient is a DNR CCA. So until the point of cardiac arrest, you can provide all standard care. So you can provide fentanyl for pain. You can pace the patient if it's clinically indicated as long as she is not in cardiac arrest. Cardiac monitoring can be utilized and Cpap is appropriate. I like to point out that fentanyl for pain control and Cpap for airway support is allowed for DNR CCA as well as DNR comfort care. So it doesn't matter what their status is, you can use those two interventions, whereas cardiac monitoring for a CC patient is inappropriate, as is pacemaker application. So this is just the form that you'll see, and you'll look to see that this patient would be marked with the DNR CC arrest. Second question is a 35-year-old female patient who's had a grand mal seizure. Her fingerstick blood sugar is acceptable at 135. Husband states she has a history of medication or seizure disorder and medication noncompliance, so she's not taking her seizure meds. What are your treatment options as she is suffering the seizure? Intranasal midazolam, intramuscular midazolam, or IV or IO midazolam. So the correct answer is D, all these are acceptable options. I think if you arrive on scene and the patient is having an active seizure, intranasal is preferred. Intramuscular is also okay. The Rampart study a number of years ago showed that intramuscular midazolam was faster than intravenous medications, mostly because intramuscular midazolam is rapidly absorbed and it takes time for you to obtain IV access. So the net effect on patients with active seizures is actually intramuscular midazolam is faster than IV in a patient who has no IV access. But any of these options are correct. Mike, any comments from the pediatric side?
I think kids' IVs are hard to get. Every kid has a nose, two nostrils usually. So in pediatrics, I lean towards intranasal, but yes, IM or intranasal are probably my two go-tos, but all of the above I would do in pediatrics as well.
And looking at from the protocol perspective, the MAD devices are preferred method. I think I mentioned as part of my protocol review for the MEC Minute, we've actually taken the dosing schedule for intranasal midazolam and put it on each of the algorithm pages for adult and pediatric seizures, so you don't have to go to MAD to get the dosing schedule. For adults, it's 10. For kids, it's weight-based, based on your estimate. So these are two boxes pulled right out of the protocol. Okay. Patient, again, question 3, it's the same patient. You've administered 2 4-milligram doses of imidazolam with termination of the patient's seizure. The patient is post-ictal and you're en route to the hospital and the patient has another seizure. you're about 10 minutes away from the hospital. What do you do next? So I would consider this patient to be in status epilepticus because they've had a grand mal seizure, they are postictal and have another seizure without going back to baseline mental status. So they are not awake and alert, then re-seize. So by definition, this patient is in status epilepticus. Your treatment options are to give the patient more midazolam, give them ketamine, be prepared to support their respirations, give them lidocaine, or should you just put more diesel into the engine and go faster? If you look at what we have in the protocol, the correct answer really is B and C. If the patient is in status or has ongoing seizures despite 2 doses of midazolam, we are going to give them ketamine at 1 milligram per kilogram IV. If we do that, we also have to be prepared to ventilate the patient because most patients with 2 doses, a total of 8 milligrams of Versed plus a 1 per kilo of ketamine, they're at risk to losing their airway or at least having depressed respirations. But our primary goal is to abort the seizure. If we have to support the respirations by using a BVM or intubating or placing an iGel, then we do that. But our first priority is aborting the seizure. The second priority is maintaining the airway. So for this patient, the correct answer would be F, which is answers B and C. From a pediatric perspective, I think the perspective would be, or the answer would be the same.
I would do C and B. No, I think it's perfect. I like it.
Yeah.
Except this is the only question I've seen that has an F.
Well, yeah, I just had to mix it up a little bit. It's one of the few questions where I could come up with more than 3 or 4 answers. This is a trauma triage question, and we're talking about geriatric trauma. So remember, we have the Ohio Trauma Triage Guidelines. It currently is the only set of patient care that's legislated and part of Ohio Revised Code. And the question is specific to geriatric trauma. So which of the following is not one of the Ohio Trauma Triage criteria? 2 or more proximal long bone fractures from an auto accident, a GCS of 14 or less with known or suspected TBI, a systolic blood pressure of less than 100, a pedestrian struck, so a geriatric patient who's struck by a car, or a fall from any height, including standing, with evidence of TBI. So, evidence of TBI for me means the patient has altered LOC following a head injury and their level of consciousness is different than their baseline. So if they're an Alzheimer's patient who already is confused with a GCS of 14, if their GCS is now 12 after a fall with head injury, that would be considered a TBI in a geriatric population. So if we look at the Ohio Triage Guidelines, this is what we have published. I know it's kind of small, but if you look at the protocol, you get better detail. And down here under the red box, one of the specific criteria is an MVC with 1 humeral or femur fracture. So really the correct answer is A. This is the one of the options that is not consistent with the Geriatric Ohio Trauma Triage Guidelines. It is not 2 or more proximal long bone fractures, it's 1 or more. And long bones are considered the humerus or the femur. So this patient, or patients who have 1 or more long bone fractures, they would meet the criteria and need to be taken to a trauma facility. The other 4 criteria listed are correct in terms of what is in the Ohio Geriatric Triage Criteria. It's a GCS of 14 or less with a known TBI. For regular people, it's 13. Systolic blood pressure of 100 or less than 100. For non-geriatric adults, it's less than 90. Any geriatric person who is struck by a car is a trauma triage or meets criteria for transport to trauma facility. And again, any fall from height, including standing with evidence of TBI, requires transport to a trauma facility. If you look at our experience at Mount Carmel East, the number one reason for admission for trauma is a fall with associated injury. So falls are very common, and we all know that our population of patients is getting older.
I think it seems like D, or pedestrian striking, is very subjective. Being hit at 90 miles an hour versus bumped into in a parking lot and just tapped.
Yeah,
I
but
mean, it's there.
Dr. Werman from MedFlight in Ohio State really was a big champion of the geriatric criteria, and if you talk to him, there is enough evidence to substantiate that as being a criteria.
And Doc, you would also say that someone with 2 or more long bone fractures, if you have the availability to take them to a trauma center, by all means, you should do that. It just doesn't fall into the category of the Ohio trauma triage.
Yeah, for others, for adults, it's 2 or more. So it is one of those criteria. So yes, but for geriatric population, it's 1. And when there's also that gestalt. If your impression is this patient has had, whether it's a geriatric or adult patient, the patient has had substantial injury or mechanism of injury where you are concerned about their well-being and the risk for a significant traumatic event, take them to a trauma facility. This is just straightforward. You have a 40-year-old female, obvious femur fracture secondary to a fall. No other injuries or vital signs are stable. What are your treatment options? So this really, I think this question for me, it's not just how are you going to treat the injury from a perspective of medication. What other interventions can you provide that are available to reduce the patient's pain? Repositioning the leg, ketamine, fentanyl, application of an ice pack. For me, all of these are viable options. I threw this in for multiple reasons. One is, you don't have to just use medications to manage pain. Splinting and repositioning helps pain. Ice packs help pain. I have ketamine on here because I'd like to reinforce that with the 2021 protocol, ketamine at 0.3 milligrams per kilogram IV push is now a first-line option for management of pain. So you can pick between ketamine at 0.3 or fentanyl at 1 mic per kilo as suitable treatment options for pain. Ketamine remains a secondary option if you give fentanyl first, but ketamine is available as a first-line option for pain management. And you can also use ketamine as an intramuscular injection if you have no immediate IV access. So if you have a patient who's pinned, you can't get to them to get IV or IO access adequately, you can give them a dose of intramuscular ketamine to manage pain. I used that in a patient and it worked very well. And if the fentanyl, just keep in mind that this year, fentanyl, the maximum dose is 4 micrograms per kilogram, dosed at 1 microgram per kilogram per dose IV push. So you can give four doses before you max out on fentanyl, and the max is weight based with a maximum dose per injection of 100 mics.
Doc, is there a reason that we didn't include intranasal ketamine as an option in pain control in the protocol?
We can use it if you need to. I just think that intramuscular is if you think about years past, we had ketamine available as intranasal for behaviorals, and how many of our providers ended up reporting exposures because they squirted the ketamine in the nose and the next thing you know, it gets blown back in their face. Yes, there's risk to using a needle, but I think I would go for the IM versus the intranasal, and I think IM works faster. Would I fault somebody if they gave it intranasally? No. This is just a basic question because I know it's been asked of me personally several times over the past year. How do you mix epinephrine for IV infusion or IV push dose therapy? You put 2 milligrams in a liter, dilute 1 vial of 1 to 1,000 epi and 9 mLs of saline flush, or add 1 milligram of the 1 to 1,000 to a 100 ml bag of normal saline. The correct answer is C. Because our current process, if you go to the epinephrine infusion page, is you take a milligram vial, which is 1 ml of the 1 to 1,000, you put it in a 100 cc bag, and then you dose it based on the infusion chart that's included. Option A is not part of our protocol anywhere. Option B is an option you may consider if you are out of 1 to 10,000 and you needed to use it for cardiac arrest. So if you want to make 1 to 10,000 epinephrine for cardiac arrest, you can take a milligram or 1 cc of 1 to 1,000 epinephrine and mix it with 9 mLs of saline and use that as an IV push. But the question has nothing to do with 1 to 10,000 in cardiac arrest. It has to do with an epinephrine infusion or IV push dose, which utilizes the options or the medication dosed in option C.
And how fast is that administered?
You titrate to effect based on the dosing. You know, for me, I start fast and slow down. I tend to like to use 2 to 4 micrograms as a starting dose, whether it's norepinephrine, which is Levophed, or epinephrine. We use epinephrine, you know, because we really don't want to start carrying norepi as another drug. So this is our way of keeping it simple. And it works for kids too.
Mm-hmm. Kids like Epi too.
Yeah, they may even like it more.
Yeah.
Finally, a pediatric question for Dr. Stoner. I'll let you introduce the question.
Speaking of kids, I know you all were waiting for a pediatric question. So this is a 2-month-old little girl. You're called. She's breathing hard. She's born a little bit early at 35 weeks, but otherwise been doing well. Sounds like there's colds and everything else in the family, but this kid's been working hard to breathe, not wanting to eat. You look at the child, and she's got just snot pouring out of her nose, her lungs. She's breathing fast. She's got rhonchi and wheezes throughout, and just retractions everywhere. So this is one of those all but questions. Which one would be inappropriate? This is a kid with bronchiolitis. It's 2 months old. Everybody always wonders, you know, bronchiolitis, asthma. This is a very young child, and there's a lot of viral symptoms, so it's bronchiolitis. So their biggest problem is their nose. So you can suction the nose out. You can give them some oxygen if they're hypoxic. You can reposition the airway, but albuterol really doesn't have a role in bronchiolitis. They've looked at it for years, and it doesn't do anything except make the kid more jittery. So the answer to this one, for the wrong answer, is D.
All right. Yeah, it used to be all kids got albuterol all the time.
Yeah, that was easy back in the day. We've done albuterol and epi, racemic epi, and steroids and everything, and nothing works.
Yeah. All right, question 8. You're dispatched on an allergic reaction. You find a 22-year-old male who's stung by several bees. This is what you see. What is your first treatment? So if you look at this patient, his lips are swollen. So from my perspective, he has angioedema. He also has hives. If you listen to the Mech Minute, you'll hear that Dr. Stoner convinced me that we need to simplify the algorithm for allergic reactions for kids and adults. So people who have minor reactions, which would be hives or itching, would get Benadryl only, whereas people with evidence of anaphylaxis would be getting epinephrine. Yes, this patient has hives, but this patient also has angioedema. Angioedema is a manifestation in part of anaphylaxis. The treatment for patients with evidence of anaphylaxis is IM epinephrine. It is your first priority and your first drug. You give it quick and early. That's why we have patients who carry around EpiPens or some type of auto injectors, so that if they have any allergic reaction that suggests anaphylaxis, they treat early. In patients with evidence of anaphylaxis, epinephrine is life-saving. I've heard medics say they don't want to use epi because it causes nausea and vomiting. Well, we can manage nausea and vomiting. Also, patients with anaphylaxis may have nausea and vomiting as a manifestation of the anaphylaxis. So it's epinephrine, and you repeat it as needed. This patient is not a simple, suffering from a simple case of hives.
Yeah, the first time I saw this, I was like, he's got hives, and I put my glasses on, and you can see the angioedema. So yeah. Epi's good. And then other stuff, you know, it's not just angioedema. It could be respiratory, which Dr. Zeeb just mentioned, wheezing, GI symptoms, nausea, the vomiting. Those are all kind of count as a second symptom in conclusion of the rash and lead you right to the epi. Yeah. And I think the current recommendation is epi fast.
Yeah, and I think I think the other options are all reasonable, particularly A, B, and C. Mm-hmm. If the patient's symptoms worsen, if you get IV access to this patient after the epinephrine is given, I would give them dexamethasone and diphenhydramine. You know, steroids take time, But if somebody's truly suffering from anaphylaxis, we throw the kitchen sink at them. And if it turns out we didn't need to be as aggressive, that's okay. But we don't want to be behind the 8 ball because we failed to do something. And IV access would be important because if they start dropping their pressures, they may need fluid boluses to maintain pressure, or they may need an epinephrine infusion at some point. Not common, but it does happen.
You're not going to hurt them by giving them this stuff, but you will by not giving the epi.
Yeah. Question 9. Engine and medic are dispatched on an unconscious person with CPR in progress. On arrival, this is what you find. What action is incorrect? So I tried to find, there's no way I could find online a picture of a pregnant woman in cardiac arrest, so I just found a pregnant woman in a VF strip. So which action is incorrect? So I'd like to really reference the change in the cardiac arrest protocols that we have as of this year, which has to do with pregnant women in cardiac arrest. So which action is incorrect? CPR and defibrillation, rapid transport, resuscitate the scene and terminate if there's no response, displace the uterus to the patient's left, or notify the receiving hospital. Well, if you look at the changes based on American Heart recommendations, the incorrect answer is resuscitate at the scene and terminate. If you have a pregnant woman in cardiac arrest, you should provide CPR, you should defibrillate as indicated. The American Heart Association recommends displacing the pregnant uterus to the patient's left. Dr. Weber mentioned earlier today that's not as easy as it sounds, but just make the effort. And then it's particularly important that you notify the receiving hospital that you have a woman a pregnant woman, particularly the second half of their pregnancy, in cardiac arrest, so they have an opportunity to mobilize their obstetrical services, because a pregnant female who is in cardiac arrest is a candidate for perimortem cesarean section in the resuscitation room. So really, we want to rapidly transport these patients. We want to notify the receiving hospital the patient's in arrest. We do not want to stay and play. So option C is the incorrect answer.
So, Doc, a couple things. I appreciate that you called me Dr. Weber, even though I'm
Oh.
not, but I'll take that.
You're in such high regard that I didn't even think about. It just came out automatically.
I'll talk to the trustees about a pay raise with that. The second thing, and we talked about it briefly, was the manual displacement of the uterus to the left, which is more difficult, but we also spoke about the potential to put this patient on a backboard and use the mechanical CPR device. That is definitely a training component, because we aren't sure how that Lucas device is going to work if we tilt that backboard. So to get that into the training regime when you're doing this is probably something to play with before you actually have the real scenario.
Good point. So for the company officers that are listening, or the EMS supervisors, please think about how you're going to train your folks to this. I think if you're using the auto pulse, it'd be a less of an issue, but I think, and I haven't tried this, if you put a patient on a backboard, tilt them a little bit to the left like you would do if they were a trauma patient as well. It's a good way of tilting that uterus, but you may have to watch the auto pulse, or the Lucas may shift, and somebody may have to hold it in place if that's what you elect to do.
Is that the patient's left or your left?
You're just making life difficult. Patient's left. And I just throw up the comment that we added to the protocol regarding the pregnant women in arrest. Question 10, you're dispatched with a patient with a shortness of breath and are advised by dispatcher that PPE is indicated. What actions are indicated on arrival on scene? You know, we could not have a protocol assessment this year without having at least one COVID question. I'm looking for the days where we don't have to talk about COVID, but we also have to recognize that COVID has kind of pushed us to do some things that we probably should have been doing all along, particularly in terms of patient assessments and use of PPE. So what actions are indicated? Standoff patient assessment, surgical mask on the patient and crew members, upgrading to Airborne Ppe for aerosol generating procedures, or commonly known as AGPs, and notifying the receiving facility that you have a PPE patient. So if you look at the revised standard or algorithm we put in the protocol about aerosol generating procedures, it's the first part of the protocol. All these answers are correct. we still want to do a little bit of a standoff patient assessment before we know what we're dealing with. The expectation should be all patients are masked and all crew members are wearing at least a surgical mask and gloves. If you're doing anything that's aerosol generating, such as Cpap or BiPAP, placement of an eye gel, placement of an endotracheal tube, or anything else that can be considered a aerosol generating procedure, all providers are expected to upgrade to full airborne PPE. I recognize that many departments are automatically using airborne PPE for all encounters, but you need to do this. And then we also want to notify the receiving facility that you have a PPE patient. I know there's been some discussion at COTS about whether the hospitals still want to be told that they're getting a PPE patient. From my perspective, just tell them we're getting a PPE patient. If they don't want to listen to you, that's fine, but I would still make that effort to notify them. So for me, all of these are correct answers. I also like to point out, as part of the protocol revision this year, if you think the patient needs CPAP or BiPAP, put them on CPAP or BiPAP, regardless of whether they have COVID or may have COVID, or if they may have CHF or COPD exacerbation. If they need a procedure, or if they need a bronchodilator by nebulization, provide the therapy, and then just upgrade your PPE and make sure you got eye protection on as well as respiratory protection. DSI question, which is the correct sequence for intubating a patient? I'm not going to read all of them to you. For me, the correct answer is B. If you look at the protocol, we use push dose epinephrine as needed to obtain an adequate blood pressure. If the patient has an adequate blood pressure or is hypertensive, we don't need to use push dose, but push dose comes first if needed. We're then going to sedate with ketamine. We're going to place them on PEEP using our tower of power. We're going to go for a O2 sat of 92 to 94% or better. We're going to administer succinylcholine, then we're going to intubate and then sedate further with fentanyl. So for me, option B is the best answer.
And Doc, you would encourage people when they're doing the training to have whatever the role is, whether it's company officer or the battalion chief that's in the back of that vehicle or wherever they're doing the DSI, is that somebody gets out the checklist and makes sure that we're following the checklist as we go through that to facilitate the DSI?
I like the checklist because depending on your company's experience, you may not do this often. I have seen several runs recently where I look at the narrative and it says that the patient was followed, the DSI protocol was followed, but if you look at what's documented, the documentation really doesn't make the point. You know, I don't see where the patient was on PEEP or the tower of power for 3 to 5 minutes. You know, I like the checklist, particularly if you're doing a procedure that's high risk or not done frequently.
We have to move the checklist into our ED for intubation just for that reason, because people would not do every step. You think you do, but you don't.
Yeah, it's just like, for me, we're audited quite heavily on sedation procedures. So if we sedate a patient for shoulder reduction or something else, we go to a checklist to make sure we get all the consents completed, make sure we have all the documentation in line, so we don't fail when the sedations are monitored. Because every sedation in the ED is monitored or evaluated by the QI folks, and we get dinged if we don't follow the process. So checklists are important. I mean, if you look at the pilots, how many times they lift off in a day or in a year, that plane doesn't move unless a checklist is completed. That's why, in terms of culture of safety, everybody uses the airline industry, because when was the last time we had a commercial plane go down in the United States with significant loss of life? And it's because they follow checklists. And they follow checklists, and anybody could stop the process. Magnesium sulfate is not indicated, so we try to bold and underline the nots or contraindicated. Not indicated for which of the following: asthma, torsades, eclampsia or preeclampsia, or asystolic cardiac arrest. The answer is really asystolic cardiac arrest. I throw this in there because we do have asthmatic patients who fail therapy. I am impressed by the number of times our crews use mag sulfate for these asthmatics. Torsades is an indication. I can't remember the last time we had a torsades in the field, but it still happens. And then eclampsia and preeclampsia. And I make this because we are seeing as much as we're trying, Franklin County is high risk for fetal and maternal complications of pregnancy. So eclampsia and preeclampsia is out there. Keep in mind that you can suffer from eclampsia or preeclampsia up to 30 days postpartum. So if you have a patient who's hypertensive, has edema, or has a seizure within 30 days of delivery, consider eclampsia and preeclampsia and give magnesium sulfate. Asystolic cardiac arrest is not an indication for mag sulfate.
Aha.
Another PD question.
All right, up another epilepsy question too. 10-year-old with epilepsy, you recall because it's a prolonged seizure. No trauma, a little bit of a sore throat, but otherwise okay. She normally takes Keppra as her anti-epileptic drug, but has missed a couple of doses. You get there, she's still having her convulsions, it's been going for 10 minutes. What do you do next? So we'll kind of go through these. Turn her aside, monitor for a full 15 minutes until intervening. You know, the old recommendations used to be 15 minutes, but it also used to involve sticking diazepam up the butt. So we've come out of that age, and it's now 5 minutes. So by the time you get there, it's time to intervene. Intubating, protect your airway. Definitely would think about that, set up for that, but we can try to break the seizure first. I think apply pressure to her nail beds and see if she comes out of it. We do see what used to be termed or coined as pseudo seizures, but she has a history of epilepsy. She's on Keppra. You can pretty much consider this a seizure and treat it as such. And then open her airway, turn her aside, and check her glucose. So of the things that are appropriate, that would be the one up there that would be the most appropriate. D.
So, Dr. Stoner, would it be, so in the current economic times, and I think people are having struggling, and we run into these patients that don't have missed a couple of days of medication, what is that kind of time frame for us to increase our suspiciousness of somebody probably is going to have a seizure because they haven't taken meds? Is it a few days of missed meds, or?
And I think that's way too variable. Unfortunately, some kids or people in general probably are in a higher dose, so they can have a longer time of weaning. Some are on that edge. And what else is going on? Is she normally controlled with her Keppra, and then all of a sudden she misses a dose and now she's going to seize? Or was she very well super therapeutic and she got a sore throat and some sickness, and that kind of pushed her over that edge too? So there's a lot of different variables in that. You know, this could have happened and she could have still been on the Keppra. It could have been written just the same. Unfortunately, I can't answer it.
Yeah, a lot of that's dependent on the half-life of the med.
Right.
So some of these meds are now available, like for sustained release, longer acting. You know, like valproic acid is available as a sustained release versus immediate release. So typically, we've always been taught, I don't know if it's changed, but typically it takes 4 to 5 half-lives before you're considered to have it out of your system. So, and also we don't know what the seizure threshold is for various people. So, you know, things like alcohol, sleep deprivation can reduce your seizure threshold, so it makes it easier to have a seizure. So, you know, it's not just taking your medication, it's taking care of yourself. So you can be taking therapeutic levels of Keppra and still have breakthrough seizures, particularly if you're sleep deprived. So you may see that like college kids, they're taking their meds, but they're staying up till 2 a.m. They're not getting an adequate amount of sleep. So it lowers their seizure threshold, which means it's easier to have a seizure. Does that make sense?
And for this kid, I would definitely intervene with some kind of a benzodiazepine, probably intranasal burst. That would be my choice, but that wasn't an option.
Yeah. This is assuming what you would do before, as somebody else is getting the drug out for you.
On the meadow, yeah. Perfect.
Yeah, we could have a whole conference on pseudoseizures or non-epileptic seizures. They can be very difficult. And Children's actually has a clinic just for that.
Clinic, yeah.
And I do use noxious stimulus in those people who I think are non-epileptic, but that's, again, another conversation. Which of the following lacks capacity to make an informed decision to refuse care or transport? The patient's dyspneic cyanotic with an O2 sat of 84%. The patient is oriented ×4. The blood sugar of 45. Or the patient is unable to recount potential risks of refusing care. So I know Chief Weber, I downgraded your status, Chief.
Thank you.
Chief Weber is a fan of checklists, and I kind of like checklists in some ways. And, you know, if you look at the checklist that we have available in the protocol, we talk about an O2 sat of less than 95%. It's not an absolute criteria, but it suggests that the patient may lack capacity. Patient who is oriented to person, place, and time probably has capacity. It builds your case. But if their orientation is different from their baseline, then that would suggest they don't have capacity. Somebody who's got a blood sugar less than 60, from my perspective, definitely doesn't have capacity. Another capacity question is, does the patient have the ability to express in their own words an understanding of what the risks of refusing are? And I actually rely on this one a lot, because if the patient can't recount to me those risks of refusal that I've given them, then I think they lack capacity. And I really don't need to go any further than that. So I just look for one reason to get that I can use to substantiate lack of capacity, and from my perspective, I'm done. If the patient has a normal O2 sat, if the patient is reasonably oriented, if their blood sugar is okay, but they can't tell me that refusing transport because they've got a STEMI could result in their death or disability. If they can't recount that to me 3 or 4 minutes after I tell them, they don't have the ability to refuse. I'm going to get them to the hospital, and we'll let it chips as they fall, as they may, after the fact. So for me, the correct answer to this is A, C, and D. The fact that the patient is oriented times 4 suggests they have capacity, but I think you need more than just that criteria to say they have capacity to refuse. But all the other items, to me, support the determination that they don't have the capacity to understand risks and to make an informed decision. Okay. So just another sidebar, when I get called periodically on the medical control line about, does this patient, do we have to transport this patient or not? If the patient, if the crew tells me the patient can't recount potential risks, my instruction is to do what you need to do, including provide sedation with midazolam to get the patient to the hospital. If you have a geriatric population and they can't understand risk, or somebody who's intoxicated can't understand risk, they have to go to the hospital. Trauma patient, female patient, hair caught in a conveyor belt with an isolated scalping head injury. Patient's confused, hypotensive, and a large amount of blood on the floor. Is TXA indicated? So, the primary indication we have for TXA is observed or considered blood loss secondary to trauma with hypotension. They're a candidate for TXA. People with scalp injuries can bleed out. We receive sometimes patients in transfer who have significant scalp injuries, and they can bleed out from an isolated scalp injury. The scalp is very vascular, and if the bleeding isn't controlled with a pressure dressing or packing, they can bleed out, and particularly when they've got bleeding that goes on for a prolonged period of time, it can just get away from them. So this patient, from my perspective, is a candidate for TXA because they have obvious blood loss, they're hypotensive, they should get TXA. Okay, you have a patient with the following rhythm. Patient has a systolic blood pressure of 70, so they're hypotensive. You went in to see the patient, and they have no visible veins. You can't get IV access, and the IO drill's in the truck. What's the next best step? Intramuscular epinephrine, immediate transcutaneous pacing, intranasal epinephrine, or for those of us who are old enough to remember when it was a fad, intracardiac epinephrine with the 5-inch needle. I'm probably the only person old enough to remember that.
I did that in that show.
Yeah, they do that all the time.
Whatever show it was.
So this we added, or I put this on here because we added to the protocol this year a statement that if you have a patient with symptomatic bradycardia, and if you look at the rhythm strip, the patient's in 3rd-degree heart block. The P to P intervals are consistent. The R to R intervals are consistent, but they don't match up. So this patient's in 3rd-degree heart block. If you don't have immediate access where you can give epinephrine, you can go immediately to transcutaneous pacing. So for me, the option here, here's the protocol where if you look at the bottom bottom right, we threw this in there. Altered LOC, IV access not obtainable. You can go to percutaneous or transcutaneous pacing immediately. So the option here is B. If you do this, the patient starts getting some discomfort because they're now perfusing. They don't like the transcutaneous pacing. You can use some midazolam intranasally if you need to sedate the patient.
No intracardiac epi.
No intracardiac epi. Although, you know, about the same time we're using intracardiac epinephrine, we're also using Levophed as the drug of last choice. Mm-hmm. Levophed is now the drug of first choice for hypotension, particularly with sepsis. So it wouldn't surprise me if at some point in time intracardiac epi comes back.
Return.
All
right. It's 2 a.m. in the morning because you didn't want to sleep. And a 3-year-old patient is there because of shortness of breath. You come to the scene. The child's moderate respiratory distress, global retraction, barky cough. He has really significant inspiratory noise or stridor. Mother says he's otherwise has no medical problems. He's a healthy kid. He had a little bit of a runny nose when he went to bed, but otherwise nothing. You take him outside, walk to the ambulance. It's a cool night, and now he appears much more comfortable. His stridor's resolved. He's got a little bit of a barky cough. What's next? This is a classic upper airway obstruction. You think about with upper airway obstruction, I think about at least 3 things. Croup, which is what this is. Foreign body is a possibility, something we always think about. He was sleeping in bed. Kids don't wake up all night and choke on things, usually. Or epiglottitis, which we haven't seen in forever. It's usually, what we do see is not acute onset.
I see epiglottitis maybe once every year or two in an adult.
Yeah.
Epiglottitis used to be a drug of exclusion, or I'm sorry, a condition or a disease of exclusion in all kids with croup. Nowadays, since they came out with the HBIG vaccine, we don't see it in kids. Right. I actually had one of my children's school teachers was intubated on the vent for epiglottitis a couple years ago. So we don't see epiglottitis in children anymore. It used to be a standard board question for the EM boards, as a pediatric question for the oral boards.
That's epiglottitis. Yeah, Hemophilus Influenza B. The vaccine started, I think, 91. So it's been around for a while, and when we do see it, probably the same as the adults, it's usually strep, and it's not, it doesn't hit as fast. So for the answer to this one, there's a lot of racemic epi answers up there, which would have been appropriate inside when he was really distressed, but now the kid has got some cool night air. He looks good. He's not breathing that hard. He doesn't need the racemic epi. The epi is just a bridge, so the answer would be C. The racemic epi will break the stridor, mostly the respiratory distress, but it's already gone. So the dexamethasone will take 4 to 6 hours to kick in, but it will decrease that swelling in the airway. If you're driving the truck and you get halfway there and it starts to come back, feel free, you can have racemic epi, but at that point, with the vignette, what it's telling you, just the steroid. And bring them in, don't send them home.
Yeah, two points I like to make. Again, if you use racemic, it's mandatory transport. No child gets left home after racemic epi because they can rebound.
Right.
What is the timeline for rebound? When does it typically occur?
The standard knee-jerk response is to watch them for 4 hours. Usually it's within the first hour or two. Some people will be a little more cavalier, but 4 hours is kind of
and we use dexamethasone at 0.6 milligrams per kilogram up to 10 milligrams.
Right.
And we've started to really use it in the field at the request of Wendy Stevens, because if we give it in the field, it's 30 minutes, 45 minutes sooner than if at the hospital, so it effectively reduces the length of stay, hopefully reduces length of stay in the emergency department.
Right. Yeah, like I said, the time to onset, peak onset is usually 4 to 6 hours, so exactly. The quicker it's given, the quicker that clock starts. And then go home.
We got 2 PEDS questions in a row.
Oh my goodness. All right, this is a 2-year-old, decreased level of consciousness. The child is otherwise healthy, I'll throw that in there. On arrival, you can't wake her up, she's cyanotic. Her respiratory rate is 8, her heart rate is 112, which is a little low for a 2-year-old. Pupils are pinpoint. Mom says she's a healthy kid, didn't do anything, she hasn't been sick. Mom's unsure because she's bedridden. She just got ankle surgery herself, but knows the kid was playing in the bathroom. This is one of those, unfortunately, guess what I'm thinking things. And that, what was it? Tricks isn't just for kids anymore. This is, opiates isn't just for adults anymore. This mom had ankle surgery. She got some opiate medication for her pain and then went and laid in bed, and the kid found them. So what would be the best appropriate step? Blow by oxygen. Oxygen's always good, but she's not breathing, so it's not really going to help unless you're giving it to her. Intubate. She may need to be intubated, but there's other stuff we can do. And then give intranasal naloxone. That's the right answer, C. And establish an IV. That is also a good thing to do, but I think for the best next appropriate step, try the Narcan and then see what you got.
So A would be correct if it said ventilate with a BVM and oxygen.
Right.
Okay. Yeah. And this is kind of like yesterday at East. We had 4 patients in the morning with unstable ankle fractures. So mom could have been one of those 4.
Yeah.
The ice. I mean, we had a bunch of ankles yesterday.
Perfect timing with the ice. Yeah. And this is more just as a reminder that opiates are starting to sneak their way into the pediatric population.
Yeah. And this is a case where we're using Narcan because of respiratory depression, not because we want to make a diagnosis.
Correct.
I continue to see patients who are given Narcan by EMS in the field because they want to make a diagnosis, not because they have respiratory depression. So we use Narcan because the patient has respiratory depression, and we give enough Narcan to have or to obtain normal ventilations so that the patient can ventilate on their own. We don't want to give too much because then the patient's in withdrawal, and now we'll have to medicate the patient with ketamine because they're combative. All right. MCI question, we always have to throw one of those in. A Greyhound bus struck a bridge abutment on the freeway. You're the triage medic. Your current patient, so you have one patient right now that you're triaging, is unable to walk, is breathing on his own, has a respiratory rate of 24, has a palpable radial pulse, and does not follow commands. What triage level do you assign this patient? So we use START, and here's the flow sheet. And if we look at the decision points, our patient has spontaneous respirations. So if you look at the triangle, that's a decision point, or the diamond, that's a decision point. The answer to that is yes, so we're going to drop down to a respiratory rate. His respiratory rate is less than 30, so we're going to drop down to the next diamond, which asks about perfusion. The patient has a radial pulse, so we're going to drop down again to the next diamond, which has to do with mental status, and the patient does not follow commands. So if working our way down the algorithm, the patient does not follow commands, so he becomes assigned an immediate category on the triage tag. I know every time we have a disaster drill, I have to look at this algorithm again, just because I need to refresh my memory. I think there are simpler algorithms out there, but this is what we're currently using in Central Ohio is START. So once in a while, please take a look at it to familiarize yourself, just in case you're the provider who gets stuck being the triage medic during an MCI. 75-year-old female with an acute left-sided stroke. On the scene, treatment includes DSI and intubation to protect your airway. The question is, what is your goal for the end-tidal CO2? So keep in mind, as of the first of the year, the MFATS board requires that any patient with an airway adjunct, whether it's a supraglottic device or endotracheal tube, be placed on waveform capnography. So we get the patient intubated, we put the patient on capnography. What is our goal, end-tidal CO2? I used to remember the days when you had patients with head injuries or you're intubating because of a neurologic condition. Our goal was to hyperventilate the patient. Well, do we still do that? Well, hyperventilation is considered one of the H-bombs, which I'll talk about. The H-bombs are hyperventilation, hypotension, and hypoxia. Dr. Spate from Arizona talks about this a lot, and he indicates that, really, we should avoid hyperventilating patients. We should use a 2-finger technique when we use a BVM, and we should use a BVM that's got a rate timer on it. So basically the flashy light. And when the light's on, you ventilate, you compress or squeeze. When the light turns off, you let go. He also advocates considering we go to a PD bag. The adult bags are over 1 liter. If you talk about adults that we put on a ventilator, we ventilate at about 5 milliliters per kilogram per ventilation, which for a 100 kilogram guy is 500 mLs. So why are we using these big bags when we don't need to use that much volume? So, we want to avoid hyperventilation, which means really our goal, CO2 with end tidal after intubation on patients with neurological injuries, whether it's a stroke or a traumatic brain injury or any other, it could be a spontaneous head bleed. Our goal, end tidal CO2 should be 35 to 40. In the old days, I would guarantee you if we had capnography available when we hyperventilated patients, we were probably below 25 because we used every cc available in that bag.
Same goes if it's a 75-month-old. Wait, how old is that? Pediatric patient.
Yes.
Same
Yeah.
end-tidal CO2 goal.
We have had some providers ask if we could just switch over to PD bags for all of our resuscitations. Not a bad idea, but if you just take 2 fingers, your index or your middle finger and your thumb, and just gently squeeze, and you start to squeeze and if we go to the bags with the light on them, you squeeze as soon as the light turns on, and it's on for a second, you let go when it turns off, and you do what the light says. I think the PD timers are a little faster. I think they're set for 20.
Probably, yeah.
But I think that's the important thing is do not hyperventilate the patient. Put them on capnography. The Ohio expectation is now that if you have an airway in, you have them on waveform capnography and you use it to monitor ventilations. Another trauma question, 25-year-old male involved in an auto accident on the freeway. He's not ambulatory, has an obvious femur fracture. He has no spinal tenderness, is not intoxicated, and has no obvious neurological impairment. Should you place the patient in a cervical collar? Well, if you look at our algorithm on spinal injuries, if you go down here, it basically says if you have an unreliable patient, you place them in a cervical collar. And one of the determinants of unreliable patient is other distracting injuries. If you had a patient with a femur fracture who is awake, I think you know how much discomfort they have. So I would consider a femur fracture to be a distracting injury, so the expectation should be that you place the patient in a cervical collar. I think everybody knows that Dr. Dizon is our Associate Medical Director for Trauma. We frequently have patients in the trauma bay with him being the trauma surgeon, and the patients have distracting injuries and they're not in a cervical collar. I think it's well proven that we do not need to use backboards, but I think it's also been proven that we need to place patients in collar if there's any indication or concern for spine injury, cervical spine injury. Certainly there's nothing significantly lost by placing the patient in a cervical collar. So use the collar liberally. This patient, in terms of this question should be placed in a collar.
Yeah, hopefully downside.
Yeah. You are assisting the charge medic with patient care. Let's just say you've been with the department for 2 months now. The charge medic indicates he's going to administer a dose of fentanyl IV. You notice him opening a vial of ketamine. Instead of fentanyl, what should you do? Should you assist in the medication administration? Take out the BVM in case the patient stops breathing? Speak up, point out the medic's mistake. Suggest you and the medic change, or at the charge medic follow our protocol on medication cross-check, or C&D. I put this in here because this is an actual case. Patient with a kidney stone, acute flank pain medication was indicated. The patient got 50 milligrams of IV ketamine instead of IV fentanyl because of a confusion over the vial. And the patient then had a transient episode of respiratory arrest. The patient awoke, his pain was remarkably gone, but he required BVM support. So this is a real case. So for me, the answer is C and D. If you look at our clinical standards, if you identify a mistake or an opportunity to improve on patient care, you are expected to speak up regardless of your stature. you cannot claim innocence because of your assigned role. You should suggest that you and the charge medic follow the protocol and medication cross-check. When I get those calls on from an EMS supervisor or a chief saying, "Doc, we need to talk," it's usually about a medication mistake. So, and if we look at the medication mistake, if the protocol had been followed, the mistake would not have occurred. So the mistakes are typically based upon the vial is confused for another vial, or the concentration of the medication is different than what's supposed to be used, and there's a mistake on dose because the wrong concentration was pulled up.
This goes back to our airline analogy. Check and recheck, and anybody can speak up.
Yeah, this is all in culture of safety. I think it's Chief Weber speak up, but I think the same would be expected at the fire scene or any other event. If somebody perceives something that's unsafe, they're expected to speak up.
Absolutely. If we'd see, if you'd see signs of a collapse that other people aren't, because they may not be seeing it. If you would see any of that on the fire ground, you would point that out for the safety of everybody involved. So this is the same scenario, just on the EMS side.
And the same is true at the hospital. Everybody is empowered. If we're doing a high-risk procedure, everybody's empowered to say stop. If you go to the operating room, and the culture of safety and what we've learned from the airline industry, if a scrub tech notices that a mistake is being made, they are empowered to speak up, or even to stop the case, depending on, in terms of some safety event. It doesn't have to do with the surgeons clamping the wrong vessel or something. It has to do with something is wrong, something is unsafe. They are empowered to speak up.
All right. This is a 4-month-old with had a period of apnea. The parents tell you that he turned blue and went limp. The history is that they fed him, laid him down, and then found him like that a few minutes later. Mom started CPR. Dad called 911, and then you as the medics show up. The child's awake, alert, smiles at you, do some vitals, and it looks great. Vitals are normal, and the kid looks appropriate. What is the best answer on this one? Check a blood sugar and leave. Blood sugar is a good thing, but the true answer is going to be C, and I'll finish up going through them. This kid had a BRU, B-R-U, a brief, resolved, unresponsive event. This kid is high risk because they're under 6 months of age, parents did CPR, and went limp and turned blue. So we don't know what causes this. The bruise are caused by, many times it is benign, but we don't know. It could be cardiac, it could be respiratory, it could be a lot of things. So checking a sugar and intervening is very good. The child does need to be seen though, so I would not leave them there and have them seen in the morning. This child is likely to get admitted, so taking them to somewhere else besides NCH, while if the other things are happening in the environment and then you just drop them off and go, that's fine, but for the most part they're going to get admitted to NCH, so that would be my first choice. There's no history of trauma. I don't think we need to take this child to a trauma center or work him up for any trauma.
Yeah, I do think we need to recognize that some of our farther out agencies are going to have to go to the closest hospital, but the preference is, if it's available as an option, is to go to Nationwide. If you go to the closest hospital, there's a good chance they're going to get transferred to Nationwide.
Anyways, right.
But
you're right. If you guys are really far out, then it does not make sense to take you out of commission for a long time. And then I think C is put in there just to think about non-accidental trauma. There's no signs of it on this child that was told to you, but it's always should be in the back of your mind.
All right. You're dispatched on an injured person. On arrival, you find a 40-year-old male complaining of acute right eye pain and blurry vision after splashing Drano in his eye. What is your first action? And I really should have underlined first. So this is an alkali injury. Drano is an alkaline substance. Neither acid nor alkaline splashes into the eye are good things, but if you had to choose between one or the two, go for the acid. Acids typically hit the eye and coagulate this external surface, but then it's done. Whereas lye, like Drano, just continues to leach into the substance of the cornea and can provide ongoing injury and damage. So what is the best option? Add sodium bicarbonate to a liter of saline and irrigate. Begin immediate irrigation with saline. anesthetize the eye with tetracaine, and then transport, place a Morgan lens and irrigate, or tell the patient to follow up with primary care in the morning. The correct option is irrigation with saline. If you have a alkaline injury or even an acid injury to the eye, the first action should be to start irrigating with something wet. We need to start flushing out the eye, and when this patient arrives in the emergency department, we will continue irrigation until the pH of the irrigating solution coming off the eye is neutral. You should not add sodium bicarb to a liter of normal saline for two reasons. First off, we don't try to use any solutions or chemicals to counteract whatever the splash is. So we don't add alkali to the solution if the patient has an acid burn. The other reason is sodium bicarbonate is alkali, so we're not going to add more alkali to an alkaline injury. So that's wrong. Option C is wrong because, you may need to use tetracaine to anesthetize the eye, but you do that in association with irrigation. Option D is a possible option, but again, it takes time to set up the Morgan lens. You may have to find it. You may have to anesthetize the eye before you place it. So it just delays care. And the question is first action. And again, E is inappropriate because this is a significant injury. You don't leave the patient behind. So the correct answer is as soon as you can, begin irrigating the eye with saline. If at some point you want to use some tetracaine, you can. If at some point you want to place a Morgan lens, you can. But you got to start the irrigation immediately. So that's the first action you should take in these injuries. These are bad injuries. Many of these patients will end up with corneal transplants.
Nice green eyes, though.
Well, the green may in part be from fluorescein. Fluorescein is a chemical we use to identify injury. You also notice if you look at the sclera, the white part of the eye, it's all swollen and red. This is a bad injury. I don't know what the outcome was for this particular patient. It was tagged as an alkaline injury. I am willing to bet the outcome was not good. If you have Drano, make sure it's in a safe position because kids also like to try to drink it from time to time. Yes. And it's just as bad on the esophagus as it is on the eye, if not worse. Here's a 27-weeker, 24-year-old female, 27 weeks gestation, complaining of severe uterine cramps following a fall. Her uterus is hard and tender. Baby was active prior to the fall, but not since. She reports a small amount of vaginal bleeding. So the basic question is, do her symptoms suggest an obstetrical emergency? And if so, what is the most likely condition? So the first answer is no, she's having Braxton Hicks contractions. The second answer is yes, this may be an obstetrical emergency from a Placenta Previa. The third answer, C, is yes, but it may be a placental abruption. D is no, it's early labor with passing a mucus plug, and E is yes, it's eclampsia. So for me, the correct answer is C. This is a fall. She's having a vaginal bleeding. I don't think you can say this is Braxton Hicks contractions, which is kind of like those cramps that females may have toward the end of their pregnancy, which is just warm up for labor. Placenta previa is a concern in a patient who's bleeding after a fall. Placenta previa is where the placenta is overlying the cervix, and you can bleed through the cervix. But placenta previa does not typically have a hard, tender uterus. And patient having a hard, tender uterus brings me to question C, or option C, which is what I think the patient has. Placental abruption, where the placenta separates from the uterus. There is bleeding, it's painful, it's uncomfortable. You may have vaginal bleeding with it, and the uterus tends to be hard. Both answers B and C, placenta previa and placenta abruption, are obstetrical emergencies. In either case, if you suspect either of these, it's immediate transport to an obstetrical facility, and you transport them as an emergency. C or D, to me, this is not early labor with passing a mucus plug, and eclampsia is not an option at this point because I didn't give you any information to suggest she's got eclampsia, which is seizure and hypertension. So for me, the correct answer is C. This is an obstetrical emergency due to a placental abruption.
So Doc, which one of those, I mean, because it's common for almost all of those to be symptoms in a OB patient that we run on, which one of those kind of raises your index of suspicion? Is it the cramping, the hard and tender uterus, the bleeding, the baby not moving? Is there one of them that you kind of focus in on to raise that level of suspicion?
Well, all the things you pointed out were to me are, I mean,
I think any of them,
trauma can be associated with abruption. Sometimes it occurs for other reasons, like eclampsia or preeclampsia can cause abruption, or it can just happen. The uterus being hard and tender, so the uterus is spasming. The uterus is irritated from the bleeding, so it's hard. I mean, typical uterus is firm but not hard. The vaginal bleeding is always a concern. Typically, placental previa is painless vaginal bleeding. So I would say anybody who has vaginal bleeding, particularly if it's substantial amounts, in the second half of pregnancy, that represents an obstetrical emergency. But for me, it's the trauma of the hard and tender uterus, the vaginal bleeding. Baby not moving is an important indication. That in itself suggests to me there's an issue with the pregnancy, but it could also be something else like a placenta previa. But I tried to give you as much as I could without saying right out front, this patient's got an abruption.
any of those would maybe transfer into.
This is one of those sacred circumstances where I would look under the sheets to see how much bleeding there is. '26 is another PD question.
Okay, so you were called for a 4-year-old, 5 days of vomiting and diarrhea. The child has not urinated in 1 day. It's listless when you arrive. His heart rate is 149, which I'll say is high for a 4-year-old. Breathing a little bit fast. Blood pressure's on the lower side. Which below is not a treatment? And we give you an IV IO access, check a blood sugar, bolus with 20 mg per kg of D5 normal saline, hook the child up to monitors, or bolus with a 20 milliliters per kilogram of 0.9 normal saline. And the answer is C. All those are actually good options with the exception of giving a bolusing with sugar. And Dr. Zeeb's informed me that that's very easy because we don't carry that. So you want to establish, this kid's dehydrated and pushing hypovolemia, is in hypovolemic shock. So he hasn't eaten, so sugar's a good idea, but establishing access and giving him fluids is the right answer for him. But you don't want to bolus with sugar-containing fluids for rehydration purposes. If his sugar's low, you would give him a bolus of sugar, but not to rehydrate him. That'd be a separate injection.
And I'm going to use this question just as an opportunity to point out, if you look at our protocol this year, we have added IV fluid maintenance rates.
Oh, yeah.
And we've also, so we have IV fluid maintenance rates. We are no longer flooding children with burns with fluids based on the Parkland formula, but children who are hypotensive based on their age are eligible for fluid boluses of 20 milliliters per kilogram for a total of 3 boluses up to 60 milliliters per kilogram total bolus. And the amount you bolus is based on their response to treatment and whether they need additional fluids.
Right. And I would say, that's why there are 20 per kilo boluses. So you do it, check, up to 3 times. At that point, it's recommended. If you're still battling with shock, then we move into some type of oppressor, but that's beyond this question.
Yeah. And if you look at the infusion rate for maintenance fluids, it's weight-based. I think it's, if I remember correctly, 0 to 10 kilos is 4 mLs per kilo per hour. And then everything else, we give you an infusion rate based on a weight range of 10 kilos. So we tried to keep it simple. In retrospect, I kind of wonder how we avoided not having infusion rates listed for all the years. It's just basically maintenance fluids, and we just leave it up to you to decide what that might be. So we tried to help you out with that. So if you haven't looked at the IV fluid rates, it's in the protocol now. We talked about postpartum patients. Here's a 31-year-old, 2 weeks postpartum. Blood pressure is 150/90, which is high. She's got 4+ edema of her lower legs and feet. During transport, she has a grand mal seizure. You already have an IV in place. What is our appropriate treatment? Are we going to give the patient IV Versed, Are you give the patient IV Versed and IV magnesium sulfate? Or are you going to provide high flow oxygen, just put her in left lateral decubitus and wait? So for me, the option is B. If the patient is preeclamptic or eclamptic, this patient is eclamptic because she's having seizures. IV magnesium sulfate is indicated, but we also have to stop the seizure. I put 2 milligrams IV of Versed. You could give up to 4. I think if you look at option C, it is partially correct. We are going to put this patient in low flow or high flow oxygen. Part of the treatment for preeclampsia and eclampsia is to put the patient in a left lateral decubitus position, but we're not going to wait. We're going to treat the seizures. So for me, B is the best option, with the first two parts of option C also being acceptable. We're just not going to wait. So the option B for me right now is answer B is the most correct at this point.
Pulse ox is dropped down into, you bounced again.
Can't go back.
Oh, I thought I gave it back to you.
No,
No,
we
you're
moved
going.
on.
Yeah. Operator error.
Too many cooks. So you've given everything, and you are still satting low into the 88% with the nasal cannula, and you want to start CPAP. In applying CPAP, what is the correct sequence of events? Do you get the right mask size, sedate with ketamine, intranasally apply the mask, initiate CPAP? Do you apply the mask, initiate CPAP, and administer albuterol via CPAP circuit and sedate the patient? Or do you determine the correct mask size, sedate, ketamine, apply mask, initiate CPAP, albuterol, period? And the correct answer is C. So obviously you need to get the correct mask size. It's kind of hard to do anything to not figure that out. These kids are there might be some kids who will tolerate it, but most kids are going to need some type of sedation. So I'm not giving the ketamine, have the ketamine ready. And then you want to put the CPAP on to help, and then keep the albuterol going. The albuterol is going to be the thing that reverses that. The CPAP is just going to open your airways up, help you oxygenate and ventilate the patient, and with more open airways, hopefully the albuterol will get a little deeper too. But I have rarely had a child with one of these masks on that did not need sedation, so that's why we've thrown ketamine in there quickly.
Dr. Stoner, can you kind of just address, because obviously the CPAP is new to us.
Yeah.
Traditionally these kids, we would instantly think we're gonna have to start bagging them.
Right.
That was don't let the respiratory rates get too low, their oxygen saturation are dropping. How do we convince ourselves to apply the CPAP as opposed to going down the route of bag valve mask ventilation and then DSI?
Yeah, I think if you're thinking that route, then go here, and hopefully we go here a little bit earlier. It's new, as you just mentioned, and it's going to be difficult. It's going to be a learning process. But in my mind, when the child will show up to our department, the emergency department, we don't automatically jump on positive pressure, but we think about it pretty quickly, and I will throw the albuterol at them, throw the IMEPI at them, and then your next thing is you have magnesium as well, but think about the CPAP. And I think just getting people to think about it as a next step, as part of the algorithm, is going to answer that question.
And part of that might be prep.
Yeah.
Again, if you're thinking about it. So it might be as you were, if you've got the engine company, let's say you have an engine company and the medic there, you have some manpower available. Somebody could be working on the child to get the albuterol going and so on, and somebody else could be sizing the child. Somebody could be at least getting ketamine available if you decide to draw it up and use it. You can get the circuit out. Maybe you don't break it out of the package, but you get it available. So some of this could be anticipatory so that you're ready. So if you think, okay, it's time to go to CPAP, everything's there and available.
I think also over time, because you guys know, as you get called by a certain patient, there's patients out there that you get called once, and there's patients that you probably get called very frequently on, and like we do in the emergency department, this kid always gets admitted to the ICU, kind of pulls our hand to be aggressive a little bit sooner. And I think as time goes on, you'll probably run into patients that are in a region that get CPAP and respond well to it. That's the year-long plan.
Sometimes it's hard to find that sweet point.
Yeah.
Between, okay, they're getting better, not getting better, let's go to CPAP versus, oops, it's too late, right? We got to go from the standard therapy to intubating the patient. So, should we, in retrospect, you go, well, should we have started CPAP sooner? Maybe we would have kept them off the vent.
Sure. And nothing here is it's not reversible. You put them on CPAP and they show up in the emergency department, you're like, they got better, so we take it off. Did it help? Did it not help? Doesn't matter. They got better. I think it's the end result.
Yeah. So, what's your experience with ketamine IM, intranasal ketamine, in terms of risk for losing airway?
I will admit wholeheartedly I have very little experience with intranasal ketamine, but we've used lots of ketamine and no risk of losing airway.
So it might be, as part of your nebulization process, if you're thinking about it, maybe providing some sedation, anticipating that if in 3 to 5 minutes, if the kid's not better, you're going to put them on a CPAP.
Right.
Any other questions, Chief?
No.
All right, last of the standard questions before we go to the 2 bonus. You have a 30-year-old male complaining of left lower leg pain deformity after a 300-pound pipe fell on him at a construction site. Has a history of IV heroin addiction and has been successfully treated with Suboxone for the past 3 years. No readily apparent IV access because of his past history. What is your best option for pain control? So, this is another one of my cases that comes from real life experience. I had this at East a couple of months ago. Big burly guy working construction, dropped this big pipe on his leg. He's got an obvious distal tibia fracture, no IV access. So what are our best options based on our current revised pain protocol? 100 micrograms of intranasal fentanyl, 50 milligrams of ketamine IM, 150 micrograms of IM fentanyl, or 100 micrograms of fentanyl via humeral IO. So what is your best option? So for me, the best option is the intramuscular ketamine. It's quick, it's easy. You can give it to him in either of his thighs. You could think about intranasal fentanyl, but I like the absorption of ketamine. I would like to avoid narcotics in this gentleman who has a history of IV heroin addiction because I don't want to re-expose him, if possible, to fentanyl. The other thing, he's actively taking Suboxone. So Suboxone will block narcotics and effects. So yes, fentanyl is a relatively good narcotic to try to battle against Suboxone for somebody who's using Suboxone, but it's going to take you more than 100 mics of fentanyl to reverse the blocking effect of Suboxone. So for me, ketamine's the best option. It's quick, you can give it IM, and it doesn't have anything to do with his Suboxone and his past history of addiction. I used it on my construction worker. In 3 to 4 minutes, he's having significant control of his pain, and it worked well. I would also have had a hard time of drilling this guy just to give him pain meds. Eventually, with using ultrasound, we were able to obtain a peripheral IV, but we had significant pain control by giving him IM ketamine. So think about it in the field. Use ketamine as first-line drug if you think it's appropriate. You can use IM ketamine if you can't get ready IV access. And I think you'll find ketamine works well in these circumstances. Okay, moving on to the bonus questions. We always have bonus questions just for the fun of it. So, which of the following has been shown to have a detrimental or bad effect on survival in a patient with a traumatic brain injury or TBI? Hypoxia, hypotension, hyperventilation, or all of the above? Well, again, I talked about Dr. Spate's 3 H-bombs. These are the 3 H-bombs. All of them have been shown to have an adverse effect on survival and outcomes in patients with TBI. This is one of his studies that he published a couple years ago. And he looked at, and the folks in Arizona looked at a database of over 4,000 patients with TBI. And they compared to patients with hypotension, a single episode of hypotension or hypoxia or both during the pre-hospital phase of their care versus TBI patients who didn't suffer any of these complications. So if you look at the odds of death in patients who had any single episode of hypotension were 2.5 times greater than those patients who did not have any, 3 times greater for patients who had hypoxia, or for patients who had combined a single episode of hypotension and hypoxia in their pre-hospital phase after suffering a TBI, they had a 6 times greater risk of dying from their head injury. So these are patients who had the same type of injury, but either an episode of hypoxia, hypotension, or both. So the correct answer to this is D. So the bottom line for us is, for patients with TBI, we need to do everything possible to avoid hypoxia, hypotension, or hyperventilation. So in the graph on the right, I didn't include his studies on hyperventilation, but all of these things have been shown to be independent predictors of bad outcomes. So yes, we need to fix hypoxia and correct it, but if correcting that means we intubate the patient, we need to avoid hyperventilation. We need to avoid hypotension. So bonus question. That's
So somebody missed the question on the H-bombs. They're probably dropping an F-bomb.
Yeah, but I'm trying to keep this, G-rated. Another bonus question. You've got a 60-year-old patient history of hypertension and chronic renal failure. Should I underline chronic renal failure there? Her ECG is on the right. What is your concern? Well, I think all of us would agree this is a funky looking EKG. But I kind of spoiled it by saying chronic renal failure. So what are you worried about? Anemia, hyperkalemia, hypoglycemia, or acute STEMI? Well, for me, the concern is hyperkalemia. So patients with chronic renal failure are likely to be anemic because of their chronic disease. They may have hypoglycemia if they're diabetic, but hypoglycemia is not going to give you significant EKG changes. This EKG to me doesn't look like a STEMI, but if you look at it, it's got really funky wide QRS durations. The T waves look funny, and if you look at V4, V5, the T waves, and V6, the T waves look kind of peaked and tall. So for me, this patient has got hyperkalemia until proven otherwise. If the patient's starting to develop worsening arrhythmias or anything else, I would treat this patient empirically with IV calcium and IV sodium bicarbonate in the field. So if they're showing any degree of instability, I would treat them for hyperkalemia based on this EKG and the fact they have chronic renal failure. I could have even made it easier for you, saying they've got a history of chronic renal failure, they've missed dialysis for the past week. That makes hyperkalemia even more of a concern. I would not fault somebody who looks at this EKG and if the patient's unstable, they look at the EKG and say, I'm going to treat them with some potassium or some calcium and some bicarb in the field. This patient is a high risk for suffering cardiac arrest. I anticipate in the emergency department we're going to give them bicarb, calcium. We're going to check their sugar. If their sugar is acceptable or even high, we're going to give them sugar and insulin. We may also give them albuterol as a nebulized treatment because albuterol drives potassiums back into the cells. So this to me is a fun EKG. This patient probably and most likely has hyperkalemia, and I'm going to treat them for hyperkalemia. Again, this is a bonus question. I just threw that in there for fun. So that's the end. Appreciate your cooperation. I know Chief Weber wanted to do this in 45 minutes. It looks like it's going to be more like an hour and 25 minutes, which is about what our average has been over the past couple of years. Typically, this takes about 90 minutes. If you have any questions or concerns, feel free to send me an email. I think the preferred route is if you have questions or concerns, take them to your EMS coordinator, and they'll bring them to me, but I'll go either way. Any closing comments from the audience?
As always, it's been fun. The one question that I wish I had put in there was a burn question. I will encourage people to look at the burn protocol for pediatrics. It did change a little bit this year. Dr. Z, you already mentioned some of the fluids, and it's less boluses of fluids and more maintenance fluids, which we have already talked about as we've added and simplified. So take a peek at that.
Chief?
No, I think great opportunities for training. Like I said, we brought up some stuff with the pregnancy and cardiac arrest, and maybe play with the equipment with your Lucas devices just to see how that works. That's not a usual situation that we come across, so I think it's a good training opportunity with several of those.
All right. Well, thank you for listening in.
Thanks, everybody.